Thank you very much. Good morning, everybody. Yes, in the next 15 minutes or so, I'd just like to give an overview of Artemisinin-resistance as it's been reported from Southeast Asia recently, and then focus on some of our recent work with collaborators in Africa to ask the question, is there now a threat there? And then just finish up with a few questions and thoughts about the implications of this for the drug development pipeline, which I gather is of interest to many people in the audience. So before we can talk about artemisinin resistance, we need to understand what we think it looks like. And the first credible report that made many of us sit up and realise perhaps this was going on far earlier than we had hoped, following the widespread introduction of artemisinin combination therapy, ACT, across the malaria-endemic world, was the work of Harry Nerdel and colleagues in Cambodia, Western Cambodia, where they saw a decrease in the speed of which microscopically quantifiable parasites were removed from the peripheral blood in malaria patients treated in Cambodia. The red line is the key one, which shows in patients that had a good serum level of artemisinin. These are monotherapy treatments in hospitalised patients with frequent blood sampling. The curve has demonstrably shifted to the right, and they're able to show some evidence that this could be linked to an in vitro phenotype from parasites taken from the same patient. This came further to the fore with the publication from Arian Dondorp and colleagues working at the Mahidol Oxford Research Unit in Bangkok, but in a field site in Western Cambodia, which showed this kind of clearance curve, whether with monotherapy or combination therapy, whereas at that time, up in Western Thailand on the Myanmar border, you still had quite acceptable clearance curves. These have since moved to the right as well in this part of the world. So by the end of the last decade, we now realise something was happening here, and it could be a serious public health threat. This led to a DFID-funded consortium called TRACK, here, the Tracking Resistance to Artemisinin collaboration. And last year they published their magnum opus, which is a very important piece of work where they evaluated, using this same approach, very close sampling post-monotherapy treatment, evaluated by microscopy, which is a nightmare to coordinate across all these different sites. But nevertheless, they did manage to achieve this. And there's a very interesting pattern indeed of slow clearing parasites still at this epicenter around Western Cambodia and into Thailand, but evidence that this phenotype is also occurring in eastern Myanmar and in a little bit in eastern Cambodia. Laos, largely free, but not completely free. In contrast, in Africa, the three sites there showed very little of this phenotype. There didn't seem to be yet this kind of parasite presence there. And these little black wedges are parasite clearing, slow clearing parasite infections, which lacked mutations in a key gene, which all of these red wedges did actually comprise. And this gene is we call it the K13 gene. It encodes a domain similar to the Kelch propeller of the human KEAP protein, and mutations in various parts of the propeller region of this gene are strongly associated with that slow clearance phenotype. So we've got a marker, we've got a phenotype, we've got a pretty good but practically difficult in vitro correlate that people are using. We've got resistance. Oh dear, these treatment failures are very worrying. But in fact, these aren't treatment failures. Because in the TRACK study, in fact, when you look out at day 42 efficacy in Pailin and other places in Cambodia and Laos, Myanmar, where you did have slow clearing parasites, in fact, the day 42 efficacy of the TRAC regimen was excellent, either before or after PCR correction. So we're not seeing classic treatment failure from these parasites. We're seeing a flattening of the initial parasite clearance curve. And that then suggests that the second regimen, which all these patients received, after 3 days of artesunate, they were all given a full course of ACT, 3-day course of ACT. So this must be the partner drug coming to the rescue. Hurrah for the partner drug. The cavalry come over the hill and mop up the parasites. But no, it's not that simple either. Here's a lovely study done a little bit earlier, published in 2011, also in Western Cambodia by Delia Bethel and actually the same group at AFRIMS that were working with Harry Nerdle a few years before. And this may not be so clear, but there's only a little bit of data that we need to look at here. This was 143 patients given 7 days of monotherapy. And what it was seen clearly, if you just look along this row, almost 50%, no matter what, these are different doses, but they were all given daily, either 2 mg per kilogram, 4 or 6. You get about 50% of this slow clearance where parasites are still present on day 3. So that's very worrying, but when you look at the day 42 efficacy, it is once again very, very good. And that's with 7 days of monotherapy. So I think this is telling us something very important about artemisinin resistance. It's the parasite adapting to a suboptimal regimen of artemisinin. And it's not about dose, it's about duration. And before the ACTs were formulated, there was plenty of evidence that a 3-day course would never do. And that in fact you needed 7 days of monotherapy, as we see here, even in the presence of slow clearance, to get rid of the parasites. So bear that in mind, because we'll come back to that when we think about the pipeline issues at the end. But nevertheless, I don't want to belittle what's been done here. This is brilliant work. A very important phenomenon has been uncovered, and the parasites have changed with these new mutations. And there's no doubt this is the threat. And there's some new work I won't talk about today that came out in Lancet Infectious Diseases in the last week or a couple of weeks from Spring et al., again from this AFRIMS group in Bangkok, showing that the combination drugs are now failing as well. So the partner drugs are under threat. So this story has got a long way to go yet. So moving to Africa, when these data came out, we were concerned about the studies we were engaged in Africa. And here's a study I want to focus on mainly today, which was undertaken in Mbita in Western Kenya on the shores of Lake Victoria. It's about an hour and a half by car and ferry from Kisumu, which some of you may know. And we were working there on the impact of ACTs on transmission to mosquitoes. And for those of you who aren't familiar with clinical trials with malaria, the drug action is all here, 3 days of treatment and then 42 days of follow-up. For most of this time, the partner drug is all on its own out here, and the artemisinin component is weaving its magic in those first 72 hours because it's very rapidly removed from the system. But we were interested not only in efficacy using normal approaches, but also in day 7 taking a blood sample and feeding this to mosquitoes through a membrane and seeing if people were still transmitting their parasites. But once we saw the Cambodian data, we thought that we needed to look at parasite clearance. So we could not see a way that in a trial in African children, we could perform this frequently spaced blood draw to get that microscopically drawn curve, which would require hospitalization of the patients. Instead, we have devised a qPCR method simply using daily filter papers at day 0, 1, 2, and 3, plus 1 at day 7, to get a clearance curve based on quantitative measurement of parasite DNA. So that was our additional secondary outcome. On the primary outcome, both regimens were highly efficacious. And on the transmission outcome, dihydroartemisinin and piperacin was a bit more permissive, significantly more permissive, of transmission to mosquitoes post-treatment. But this is still a vast improvement on non-artemisinin drugs in terms of onward transmission. And then here's the qPCR assay, which we've been using. And this was originally tested on patients in the hospital across the road who coming back from various climes with malaria. This person had a high parasitemia, and these represent triplicate qPCR curves from 6 sequential daily samples taken from that patient under artemisinin treatment. And what we do is we simply put a DNA sample extracted from the blood. We don't even have to measure it because we normalise this signal to the signal from a human gene in the white blood cells. So it's kind of a molecular white blood cell count to normalise our parasite counts, and we get a lovely robust estimate of parasite clearance from that, irrespective of how much blood goes into the sample. So by doing that, we were able to show that, in fact, in Kenya, in this group of patients, even though of the 300, only a single child was microscopy positive on day 3, about 35% of the children were qPCR positive on day 3. My initial thought was this is noise in the system. The assay is not doing what we'd hoped. It's picking up some DNA floating around in the blood. But then we were able to see that those that had this signal at day 3 were much more likely to have recurrent microscopic parasitemia 4 or 6 weeks later. So in other words, picking up a microscopically invisible PCR detectable parasitemia at day 3 was a very strong predictor of recurrent parasitemia 4 to 6 weeks later. Asexual parasitemia identified down the microscope. So that is true treatment failure. These are persisting parasites that were present at treatment but not detected by microscopy. There was also some relationship with the transmission endpoints, but we don't need to consider that at the moment for today. So this has also been published recently in JID, and I can refer you to that paper if you want to read more about it. But then, of course, we've got 2 questions immediately arise. The first is, what is special about these parasites? Are the parasites persisting at day 3 submicroscopically different from those that were cleared? So that might suggest a parasite-encoded resistance mechanism. And also importantly, are they anything like the Cambodian parasites that are causing so much angst in Southeast Asia at the moment? So again, this work has been published, so I'll rush through it, but basically we found, irrespective of the regimen given, the 2 genes most closely linked to chloroquine resistance in the past were heavily selected back towards a chloroquine-sensitive genotype. So at day 3, you were much more likely, if you were positive still by PCR, much more likely to have a chloroquine-sensitive parasite than at day 0. And we even saw patients switch, which simply means that in a complex infection treated with ACT, the chloroquine-resistant parasites get knocked down first, and if any persist, they're more likely to be chloroquine-sensitive. But interestingly, these 2 new loci, originally identified in P. Shabodi experiments at the University of Edinburgh, also proved to be strongly associated with persistence at day 3 in the case of AP2-mu. And because we'd used up all the filter papers doing these originally unplanned experiments, for UBP1, we looked at the failure day samples and found a very strong relationship with the recurrent parasitemia at day 28 and day 42. So we've repeated this study and are yet to analyse all the data, but hopefully we will have clearer evidence of that. And this isn't just an East African thing. This is just a quick heads up that in our West African Wanakam consortium led by Abdoulaye Jimde, we're seeing evidence of a similar qPCR detectable persistent parasitemia in 20 to 30% of children, depending on the site. And it seems to be roughly proportional to transmission intensity. So this was published by Gisela Henriquez, who did this work as part of her PhD, using the assay that Khalid Bashir had originally developed. So, is this artemisinin resistance? Well, in fact, as in Cambodia, the regimens were efficacious over the full follow-up. We saw no evidence of the Kelch propeller protein mutations, and the mutations that we see here are not present in Cambodia. So it doesn't look like the Cambodian resistance. And we have been able to show that when we make transgenic parasites carrying some of these mutations, we get a change in IC50 against both DHA and quinine in vitro. So this pilot experiment that we've published here just recently in AAC does suggest that these changes can be seen in vitro in transgenic parasites. So thanks for your attention, and I'm indebted to many collaborators who worked with us on the field work, and that was an FP7 consortium led by Henk Schallig, who's speaking here tomorrow, and all the people in the lab team that contributed to the work. Thank you.